Welcome to our Plenary 4, How to Make It Happen on the Development of People and Institutions in Public Health. May I introduce to you, before I come to some general remarks, the podium so that you know who is sitting here. On my far right, Marianne Olsson, she is the president of the European Health Management Association, EMA. Then we have Professor Piot, the Dean of the London School of Hygiene and Tropical Medicine. And here we have our Stampa medalist from this year, Professor José Moreno, and he is the academic director at the School of Public Health in Valencia and former director of program management at WHO Europe. One is missing, who is mentioned in the program, and one is additional. Professor Julio Frank, the Dean of the Harvard School of Public Health, could not come, and he sent a video message that we will view later. And Professor Moreno was so flexible and a good friend that he said, of course, I step in so that we have a podium where we can discuss. So I'm very grateful for our podium that you could make it. And in a way, we are coming to the end of this conference. Okay, tomorrow we will still discuss. But there were several ideas, I guess, that are around in the podium, how we can develop the public health workforce and what institutions we need. And I would like to start this plenary with presentations from the podium. And I would like Ms. Olsen to start and to give us her view on how important the management of public health institutions is. Jean Monnet once said, if you want to start a good idea, you need a person that is committed. But if you want to have sustainability, you need institutions and organizations. Marianne, I think that is something your talk will cover. The floor is yours.
Thank you so much. And a big thank you for giving me this opportunity and for inviting me. I feel very humble in this very distinguished company. I am not a researcher myself. I come from a managerial background. I've been a manager in both social services and in healthcare. And I've worked with quality improvement on all levels, national, regional, and local. And at the moment, I am the president of EMA, the European Health Management Association, an association that brings together policymakers, researchers in healthcare, and healthcare managers. The speakers who opened the conference talked about the two phases of public health in Europe at the moment. On the one hand, we are here to celebrate the fact that health is actually improving all over. That is something to celebrate, and I celebrate you because I think many of the people present in this room have contributed to that fact. That is wonderful. But I wanted to share with you today some things that trouble me. And they all have to do, more or less, with the fact that even though health is improving in Europe, we are seeing an increase in the social inequity. Recent programs and studies that we are doing at EMA is indicating that not all countries in Europe are seeing an improvement. There is even beginning signs of a decline in some countries. I'm Swedish myself, and what we've seen in Sweden for quite a while now is that the social divide when it comes to healthcare is increasing. It's increasing every year. And although health is improving in Sweden, When you look at women in the lowest educational group, we haven't seen much improvement over the last decade. It's a standstill. At the same time, the women in the highest income group have seen substantial increase in health. So if we want to make it happen, it's clear to me that what we need to address is the social inequity in health. And looking at that, and looking at how we are supposed to make it happen, what we need from people and from institutions, there are three things that worry me. The first of them has to do with the fact that working on a meso or a operational level, there is very little guidance. What should a city council or what should a hospital director do to address the social inequality in health? I saw a recent example that I think says a lot about the situation today. This was an advice given to a city. And I'm just taking one example out of many. The city was proposed to set up as a goal: the city should actively work for equal income. And as an activity, the city was advised to monitor income equality and take actions to compensate for the effect of it. That, my friends, is not of much use to a city. We need much more guidance on the how, on the change concepts that actually will work. There is a lot of knowledge hidden within your heads and within your publications that need to be chiseled out so that it can provide real guidance, not just for nations or European Commission, but I think that excellent advice and excellent guidance already exists. But the same kind of guidance need to be developed for other levels in the system. The other thing that worries me, coming from healthcare, and with a background in social services, of course I'm fully aware of the fact that healthcare is not the main actor when it comes to public health. But I was very happy yesterday when I listened in one of the seminars to Professor Steven van der Broek, who said, we haven't exhausted the resources of healthcare. And I would like us to talk about and to think about ways of including healthcare in the public health work. Today, what I've seen in Sweden is the fact that healthcare does not compensate for social inequality. On the other hand, it actually worsens it because there is inequality in the delivery of healthcare and not compensation. And apart from that, healthcare has quite a strong voice and can advocate for public health. So please don't exclude your friends within healthcare from the public health work. Last, in several of the seminars that I've attended at this conference, people have been worrying about the same thing that I do, and that is the lack of the voice of public health in national and international debate. I think that the voice of public health is heard in Brussels and at a European level. but I lack the voice at a national level and a regional level. I lack the intervention of public health knowledge in debates on healthcare, on austerity. You have so much to share, and I would welcome brave public health researchers and officers taking a part of the political debate and making the voice of public health heard in a much clearer way than today. Having said that, the initiatives of ASPER and UPA on developing the European Schools of Public Health, I think, presents some of the answers to my worries. Working together, bringing in the voice of the patient, the population, working on educating healthcare professionals. There are loads of things that the schools of public health in Europe could do together, and the European Health Management Association welcomes these initiatives, and we want to be a good example and to further the cooperation between public health and healthcare management. Thank you.
Thank you very much, Ms. Olsen, for this presentation. I would now ask Professor Beer to take the floor. And in between, I would like to inform you that, of course, what you said, taking part in the debate, ESFA tried this to do. We developed a charter of ESFA, and the title is The Global Dimension of Education and Training for Public Health in the 21st Century in Europe and in the world. And we will have a presentation after this, a discussion about this too, so more things to come. But now you are ready, the floor is yours.
Yeah, thank you, Helmut, and good evening, everybody. I've been asked to reflect on, what kind of public health capacities do we need to perform well and to have an impact on people's lives, and then also reflect on the challenges and all these opportunities that lie ahead of us. And I'm grateful to Martin McKee, who helped me to prepare this intervention. And it's unavoidable that I'll draw on my experience, particularly in terms of the AIDS response, particularly from my time when I was head of UNAIDS. I would like to make basically 6 points, more than double the normal ones, but I think they're all important. And first of all, I think that as a community and also as a broader society, I think we fail to recognize the scale of the challenges that we face. That was certainly the case when in the early 80s, AIDS came out of the blue, and we underestimated it, and as a result, we lost enormous time, and more importantly, many lives were lost because of inaction. But the same is true, I think, is that we fail today to recognize the major impact of the crisis, of austerity, on people's lives in general, but also in the health sector and for public health. And also, I think we're failing to recognize the enormous epidemic of chronic diseases, of the so-called non-communicable diseases that are really coming as a tsunami all over the world. And at the same time, I think we may be politically naive and failing to recognize the power, the resourcefulness of those that are driving this epidemic, particularly the tobacco industry, the alcohol industry, and then some of the food industry, particularly. We saw it last week, or was it this week, the vote in, at the European Parliament on tobacco product directive, where there was massive and very effective lobbying by industry, and with a result that is really bad for public health. So the battle against the tobacco industry is far from over, and I consider as probably the #1 battle that we have to fight as a public health community. And I can go on and on and on and on. But also, I think that we have to see that we can not only raise awareness about it, but also that we need to use the information that's already there, the tools. I'm currently chairing a meeting here in Brussels of an independent advisory group overseeing the global burden of disease. We could really make much more use of that kind of up-to-date information and for all our members. Secondly, I think that for me, a foundation of public health is to reducing inequalities, just as we just heard from Jan Olsen. And as public health practitioners, academics, whatever it is, we need to speak out on behalf of the most vulnerable in society and give those without a voice a voice. And that was definitely a major issue in, from the AIDS response, where stigma, discrimination, and human rights violations were as important as drivers of the epidemic and as a problem for the response as any biological or financial issues. And it's only through a coalition, a strong alliance between those of us working in public health and people living with HIV and activists speaking up on behalf of their own communities that we really have made a major impact. And I'm glad to see that there were several sessions at this conference on impact of austerity, on Roma, and all the problems that we also have in Europe in terms of growing, there's no other word, hatred against immigrants and recipients of welfare. Public health is only worth taking on as a job and as a mission if we speak up and we safeguard the interest of the vulnerable. Thirdly, we need to confront the fatalism that says that nothing can be done, that it's too complicated, that people have been, will always be the way they are. This was one of the things that I heard when we started with a response to the AIDS epidemic. There were probably more time was spent, particularly by public health officials, I must say, and public health academics, development experts, and so on, to say why it is actually impossible for people in developing countries to have access to life-saving antiretroviral therapy, for a whole range of reasons. And all these reasons are reasonable and by themselves, but instead of investing energy in doing something about the problem, the energy was invested in in making lists of why it's impossible. And but it happened. We decreased the price of antiretrovirals for low and middle income countries, mobilized the money, mobilized the communities. And in the same vein, people thought that it would be impossible to ban smoking from an Irish pub or a Belgian cafe, and said, just forget it, it's impossible, because I don't know what they expected, revolution or so, but it didn't happen. We really not only should make sure that we are ambitious, provide also incentive for those politicians who we have convinced that yes, this is a problem, but maybe lack a bit of the courage, thinking of the next election, that they should take measures that are in the immediate not very popular. But there are enough examples in the world, in Europe, outside Europe, to show that it is possible. If today you can't even smoke in Central Park in New York City, I mean, that's a matter of leadership, and it didn't come from someone who was really could be suspected of being absolutely a regulator. We should also stress far more in our messages that we have made achievements. Success, I think, is not the right word. When you see that there has been a a decrease in deaths from cardiovascular disease by 50% all over Western Europe in the last 3 decades. That's not known enough. And that didn't come out of the blue, that didn't come by accident. So I think we really need to confront that fatalism, because that and cynicism, these are big, big enemies of what we're trying to do. I would say we have evidence-based optimism. That's something we can ground them. Fourthly, is that this obsession that we find, particularly in academic circles, I would say, but also elsewhere, the search for the silver bullet or the magic bullet. That magic bullet belongs in the dustbin of history. When I was director of UNAIDS, I regularly got emails and letters and so on. It was, "Dear Dr. Piot, if only you would," and then you can fill in whatever was the fashion of the day or the hobby of the day, "you would do so and so, you circumcise all men, or you treat everybody, or you test everybody. We will stop this epidemic for you." Sorry, that's not how it goes. And in population health, you know, everything we do today requires a structural intervention, regulation, marketing, you know, perhaps a vaccine, behavior change, some biomedical measures. And so it is really through combination prevention, in this case, that we you know, we will succeed. That doesn't mean that our messaging has to be equally complicated, because then we have no chance. We need an elevator speech, we need the so-called solutions, but we shouldn't mix up that elevator speech with what we actually do in practice. And that means also that we have to unify our forces. One of the biggest problems in public health, I think, are public health experts who can't agree. And it reminds me of what Sigmund Freud said, you know, about the narcissism of small differences. You know, where in academia it's fine to fight over small differences, and that's how science progresses. I have no problem with that. But when you got into the public scene, that can be disastrous. Again, when I was head of UNAIDS, I would get experts, scientists coming to tell me this is what you should do, and then next week another delegation, other people who start bad-mouthing the colleagues and then saying that they're incompetent and no, instead you should do this. So we need this unified front, but not for the silver bullet. Fifth point is that I'm deeply convinced that we have no chance of improving health of any population on a large scale if we stick to the health sector alone. If we stick to biomedical approaches or public health messages or whatever. We need to go outside the health sector. Some of it is regulation, so we need, you know, a political approach. We need sometimes anti-discrimination measures and so on. And as I said, we need also as much the marketing people as the regulation people to have on our side. So go out of our silos, and I'm talking among ourselves. So how to do that is a big challenge. And I think in training of public health, people in public health, we need to provide them with the skills of dealing with power relations, because that's what it is all about. And finally, nothing can replace speaking truth to power. Again, when you look at the history of public health, starting, let's say, in the 19th century, it is really always was a matter of taking up our responsibilities, social injustices, but also plain public health issues. And that certainly was the case when it came to AIDS. But I must say that in the early days of AIDS, the public health community in Europe, in the US, was silent. WHO was silent. You know, the schools of public health were silent. And I feel that we may have a bit the same situation now, that I don't hear voices to stand up about the disaster that is unfolding in terms of public health in Southern Europe, in countries that are, you know, victims of the financial and economic crisis, and Although, I must say, a tribute to European CDC has spoken up, and I must say also out of our school, the London School of Hygiene and Tropical Medicine, but it's really, as a community, we should do more. So where does that leave us? I think I'm very optimistic about the future of population health and public health. And maybe one reason for that is, it's not such a good one, but all our healthcare systems are on a train wreck scenario, whether it's the National Health Service, a fully publicly funded service, or a mixed model like in this country or whatever. They're all in trouble for good reasons and bad reasons. Good reasons being longevity and shift in, in demographics and so on. So that's part, victims of our success. But also sometimes for bad reasons because of mismanagement and the nth, reform. But it's simply the current systems are no longer affordable. And so what I'm hearing more and more is that not out of the health sector and the health professionals, because we have a conflict of interest. We want a statu quo, particularly in the medical community, but from Treasury, ministers of finance, where they say, wait a minute, we can't have every year another X% increase in the budget. Forget it. So we need to work far more upstream, and that's where public health comes in, and that's where we have to prepare for that and position ourselves for that. So that means that the first point is we need to go beyond our technical public health comfort zone and make sure we reach out to other sectors and not waiting until they come to us. Secondly, I think that we are at a turning point in terms of training of public health. We're rethinking it. The ASPER Charter that we will discuss later on, it's a good example, and many other places. As I mentioned, for example, we need as much political science in there than epidemiology. And thirdly, I think that building institutions both at the national level, sometimes subnational level, and at the European level is really a key priority, particularly in times of crisis. And personally, I was last week in Stockholm at the European Center for Disease Control, and here we have an institution at European level with limited mandate, too limited as far as I'm concerned. You can't have an institution that only deals with infectious diseases today. We need to expand that, and it needs to become far more autonomous, liberated from bureaucracies and political control, so that it can work together with strong national entities for public health to make sure that our citizens have access to the public health that we deserve as a continent. Thank you very much.
Thank you very much. I think that are interesting points for the discussion. Now we will try out what about those new technologies. Can we make it happen that we can get this video presented to us? That will be the first test now if this will work. And at least the light. Okay, let's give him an applause. So at least it doesn't compensate the personal experience, but at least we got the message. So that I think is a good thing. And of course, we got an impression how they do the things. But I'm personally very happy to have our Stampe medalist here on the podium. And he agreed to have some comments on this.
Thank you, Chair. And it's a privilege, but at the same time, I don't know, you will be very pleased at the end when, because I have so many, I would like to say so many things. And actually, I have not been prepared because it was really by surprise. But at the same time, I'm very motivated to make some comments on these ideas. Previously, obviously, I acknowledged the excellent presentations by Mario and by Peter, but particularly on the Julio Frank's aspects. And there are many of them logically arising from the Lancet Independent Commission on Health Professionals for New Century, nicely put together, but there are contextual issues that I would like to add to Dr. Frank's presentation. actually European issues also, because we have also the Bologna movement, and actually in order to try to give coherence to our professionalism throughout Europe. And these principles of things that sometimes we repeat a lot, but are about knowledge, about obviously skills and attitudes, which are very important. We had the other day a pre-conference. We need to even to move on more and more from being advocates to be activists sometimes. So it's an attitude. It's really a belief. It's a passion. It's a way of communicating to ourselves. So, and actually the session was on how to make it happen, on the development of people and institutions in public health. And I like it a lot, and I am a Harvard alumnus, so, and a personal admirer of Julio Frank. But I like to underline something expressed in our ASFER Charter on the global dimension on education and training for public health in the 21st century in Europe and in the world. And this has to be explicitly stated, that we have key health problems today that transgress national and even continental borders. And we need actually to tackle that. And we need to include this in our curriculum in a very explicit way, and should be really crystal clear. Not only air and water pollution, all the climate change, the lifestyle change conditioned by the contagious social environment. We call it contagious diseases to infectious diseases, but actually the contagious diseases are those by marketing, by fast food, and so on. They are communicated. So we need to tackle this. This is all the demographic dynamics, all the communication revolution, obviously the natural disasters, the military conflicts, and obviously the financial crisis and the inequity between and within countries, which is so appalling that we cannot help but just stand up and say enough is enough, and we need to do our best at least to contribute to tackle these problems. So therefore, also complementary to what Julio Frank presented, I need to underline the recognition of the global dimension of education and training for public health, as we were trying to put in the charter, that actually Julio also commended, and the leadership based on agreed long-term perspective. And actually, there are different instruments that we should take into account, and I'm sure that in the discussion, especially young professional students and so on, will be very interested to know how can we articulate solutions for that, and then how to have international mobility organized efficiently for students and teachers. This is going to be excellent for the future, how to invest in this kind of programs that will help us to cross-fertilize, and obviously how to foster the synergism with UFA, IFA, IMA, EuroHealthNet, with all this, and then communication is essential. And I come back to one thing that actually Peter was saying before, the fatalism. Actually, I was saying that we all make mistakes in our life, but there are different ways of dealing with mistakes. There are people who say, no, I didn't make any mistake. They do not acknowledge, no, it's not true, no mistake. There are others who say, yes, but it was not me. It was because of him, because of her, and blaming others. This is very typical. But there is a third group of people, and we public health tend to be that tend to be fatalists and say, oh yes, it was us. We were such a disaster. This is very difficult. So somebody else will have to do it because we were there and we were not successful. The reality that we have not been completely successful, we have made many mistakes, but we try to do our utmost. We are relatively good and we can be better and we have to improve. And I think this is a very important thing to say. And then, obviously, we like to put this in the European context with our weaknesses, but also with our strengths, with our the diversity, which is part of our headaches, but also part of our beauty, with our financial crisis and budgetary constraints and rigid labor markets, and then governments that they don't talk to each other, but professionals that they talk to each other. And I feel the solidarity, and I'm thank you for that, because this is important. With the need to assertively define our workforce needs. Actually, we have even a Health 2020 strategy. So saying that we need a whole of government, whole of society approach, and based on equity principles, somewhat forgotten during the recent crisis, but inherent in our European culture, in our blood, which is over more obvious when we see what has happened, I think yesterday, to the Obama healthcare reform. So actually, this makes us happy. And think about this. I was just reflecting on a visit that I did to Boston. I was speaking with my colleagues there, And our question and our concept of fairness is different from the concept of fairness of many key influential North Americans, which is, I'm not going to criticize them, it's a different thing. They say in terms of social security, in terms of Medicare, or fairness means that each person should get out exactly what she put in with interest, and that their money should never be used to pay for somebody else's care that would be unfair. This is fairness. For them is, okay, you want to have a good social care, and you pay for it. You prefer to have a good car, you pay for the car. But then don't ask for the social and health care, don't ask me to pay for it. This is the concept of fairness. But for us, and we are very proud, and I have been, it's a social good. Health is a social good, it's not a market product. So this is solidarity, is understanding that all citizens are part of the same community. They should have been treated all equally within the community. And we should think about this in the European Union, what is happening or not. And the community is noticeably strengthened when this collective approach is taken. We believe in Europe in the community-based fairness. So the understanding what is fair is collective and need-based. We believe also in the mandatory involvement and in the public regulation in order to ensure that this is delivered in the proper way with citizen participation. So I believe that these values, we need also to be assertive, obviously to know we are not perfect, not at all. We make many mistakes, but we have a lot of ground to build, frankly, in the best possible way in order to tackle this issue for public health. And finally, I would like to say that obviously, within that, another key concept that need to be added to this instructional and institutional kind of dimensions with the different cultural aspects and actually the knowledge, the skills, and the attitudes is that we are trying to move the acknowledgement that health is not just the goal of the Ministry of Health, but also the government and the society as a whole. So we need this formative, using Julio's terminology, formative and transformative levels of learning of the instructional dimension. They need to instill the idea that the old leadership models are no longer valid, or at least exclusively valid. We cannot go only with vertical hierarchies, network approaches with unidirectional or even bidirectional communication for the health system. We actually need to work with other sectors, and this need to be developed in our curriculum. This is a must. And linked to that, the competencies enhance this idea of the communication. This is so essential, communication. I mean, again, it's communication to others and with others, because it's two-way street. Sometimes we forget that this is very important to listen. And also to ourselves and with ourselves to understand what is happening and how can we improve in order not to be lost in translation and interpretation. We are not there yet, but actually we have many things that can be done. I would love to speak about just one piece for the debate, which is, I think, essential for the future that many colleagues here have been working on, and that I think would improve a lot our capacity to convey the message and to be much more successful in public health, which is knowledge brokerage. And the Observatory has been working on that a lot. We have to actually, respecting the classical and standard way of dealing with scientific papers, with narrow focus hypothesis, with dealing either with the cause or with the potential solution or the implementation of the potential solution, but in isolated silos, the policymakers are expecting us to treat the different things at the same time. And instead of giving them a solution and at the same time with a p-value, which means a random error, type 1, so say, you will have to do that, but I'm not sure. This is what they receive. Instead of that, what they want to have is a set of alternatives with pros and cons, and actually with evidence-based exposure of what is happening. If you do something, and if you don't do something, which is another kind of action. And from that perspective, this idea of fostering policy briefs, policy dialogues, exchanging views in a much more dynamic way, I think we are going to gain a lot in public health. Thank you so much.
Thank you very, very much. Marianne, when you listen to this and you see young faces and old faces in the audience, so we have those who are in education and those who need a fresh up in lifelong learning. And we heard there is no magic bullet, but what are the upcoming trends in management, in health and healthcare, where we all should have now enrolled to the next training courses? Is there something that's coming up for the future?
Yes, thank you. Yes, there is, I think. And it's a trend that links healthcare very closely to public health, I think. Or there are two trends, I would say. The most important one being developing a patient-centered care, and not just talking about patient-centeredness, but actually transforming healthcare. And I think we are facing, because of the challenges that you, Peter, painted a very clear picture of, are facing a transformative change of healthcare. And I mean healthcare, into a patient-centered system. And I think there is very much mutual learning between. So that's what I would recommend for the young and the old. And the other one being the going upstreams. And I see a lot of interest within healthcare of understanding and working together with communities to achieve this. I see a lot of health professionals coming out of the hospitals, willing to engage with communities and willing to work upstream, because they see the effect of not doing it, and they do understand that if we don't, we are in a fast, what did you say, Peter, a fast track to what?
Train wreck scenario.
Yes, to a train wreck scenario. And the understanding of that situation is growing. So patient-centeredness, public health are trends in healthcare today. And I think there is a growing understanding for the need of working together and integrating public health and healthcare. The boundaries are dissolving, I would say. Yeah.
Thank you for this. Before I come to Peter, I would ask Professor Birgovic if she could move already slowly to this, so to give us then a little overview about the ASFA Charter. Peter, you talked about fatalism and so on. Perhaps you can help me. Now, a really big number of public health specialists are civil servant, work as civil servants and for the government. So they have a quite high job security. But the funny thing is that those people having a training in public health, having higher job security than the rest of the population, are afraid to speak out. Yeah. Do we recruit the wrong people?
First, before that, I would like to fully support what Marianne said about the artificial boundaries between public health and clinical care and healthcare services. And as long as that schism continues, I think we will, pay a high toll in terms of lost, wasted resources and so on. Now, are we recruiting the wrong people? I don't think so. I mean, it is true that public health in most administrations is not the most glorious type of career path. And that's what we need to change. And I think that's what I said, where I feel that we should think through how we can position public health, which means population-based health and preventive health and well-being. I think we should, the National Health Service in the UK, that's the wrong term. It's the National Disease Service, and we need to turn it into National Health Service, which means a strong connection between care and prevention, but also with social welfare and others. And I think that it can be made more prestigious, I think, if we can reposition it. If we continue the way it is now, I doubt that we will do that. And I think also we need to make sure that there is far more, mobility between, let's say, in academia, where, you have academic freedom, you can say what you want, it usually has zero impact, but anyway, but it can have, if it's well connected with you know, people who are in official positions. And that's, I think, could be a very smart strategy where we could help. But it requires some courage, yes. But now, let's not forget also that in many countries, like in Sweden also, now in England, it's at a more local level that you find public health practitioners, where they are held accountable, and yet they meet the people in the street or in the pub or whatever who are they supposed to work for. And then it's far more difficult to escape the kind of accountability.
Vesna, I have a burning question to you, Josef. Please excuse me that I let you. In a way, what you said, you reinvented the public health trias. Assessment, policy development, assurance. Assessment, we have to know how the situation is. Policy development, we have to develop options for the politicians to choose from, because not everything would be applicable. And then if they made the decision, the assurance that this change happens. Is this something what you thought of?
Yes, and let me say it in a very simple way. I hope simple, not simplistic, but actually there is something that I reflected a long time ago from a very good friend. He said there are many principles without continuities, and there are many continuities without principles. Okay, what we are doing this, I don't know. I mean, somebody invented this. You have to do that because you follow that. But then I think this is a concept that we need to keep in mind all the time. I love the term in English of integrity, but not in the terms of being ethical, or it's wholeness, obviously. Wholeness, coherence. We have to feel what we believe, and I think we have a set of beliefs, those of us who are in this conference. Then we have these beliefs, we have to convey them. We need to feel it, to say it, and then we need to do it, and to be really coherent. Sometimes we speak a lot about cooperation, about accountability, about solidarity, and we should look at ourselves. Are we really solidarious? Are we working as much as we could? Are we synergistic? Could we try to do it? And again, I am not blaming anybody, I'm blaming myself, but we can try to do this. And it is true that first you assess, you think that what needs to be done, then you take action, you monitor that what you have done is relatively reasonable or sensible, and then obviously you continue in this logical way of giving sense to your life for a good cause. And I am very convinced this is the way to go.
Thank you very much. Vesna,
Yes, Helen.
you are now the new president of ESFA. And congratulations again from here. And now there's suspense. What is this charter that ESFA will have now? And it's about the global dimension of education and training for public health in the 21st century, in Europe and in the world. And can you please introduce this to us? Because I think it will be an important document.
Yeah, thank you, Helmut. First, I like to say that I was really inspired and impressed with our speakers today at this plenary, because somehow it brought me, dear colleagues and friends, to the fact that we really have to act together, and we really have to find as much as possible people around us who will say to us how we can do something and not how we can find the reason not to do, which I like very much what our colleague Peter Piot stressed in his presentation. I also liked enormously to hear that we have here one lady who is really strong lady and calling for leadership in public health. Because without leadership, tomorrow we can adopt several charters and declarations, and we will be still stuck with many problems of the world. And finally, but very important, our Stamper medalist, ASFER medalist, our friend Jose Maria Moreno, who reminded us again that without education and the proper way and link to practice of public health, we would not have that knowledge and strength to fight against enormous public health problems. And before I say a few words from charters, which you can, I am sure, take and look in depth in the piece and decide to act upon it,
I would like also to remind on recent words of Dave McCoy, who identified 6 solutions to solve the problems of the planet, not only of Europe. And he said that he saw and see hope, courage, knowledge, imagination, organization, and public health. And at this conference that really gives us hope that we can go in strong way. And now it's my honor, as I said, to present the Charter to the Global Dimension of Education and Training for Public Health in the 21st century in Europe and in the world. Please let me know that I read these parts. ASFER is founded in 1966 as the key independent organization dedicated to strengthening the role of public health by improving education and training for public health professionals, for practice and research. Since the early 90s, Europe is growing together again, and ASFER contributes to that under its mandate. Europe is also part of a rapidly integrating world and shares responsibility beyond continental borders. And for all of us, it is commonly known that the key health problems of today transgress national and even continental borders, including air and water pollution, climate change, lifestyle changes, conditioned by the social environment, demographic dynamics, the communication revolution, the heavy toll from natural disasters and military conflicts, and last but not least, the ongoing financial crisis and the inequity between and within countries. Both education and research are core composite parts in the development of globalization, with international students numbering 2.5 million globally today and constituting even 20.5% of the total enrollment of the European schools of public health. Global health is an urgent topic of highest relevance in the public health academic curricula, but there are serious misbalances, with academic programs being frequently organized by institutions in high-income countries without adequate involvement of recipient countries in setting priority topics. Efforts are underway to globally harmonize underlying essential public health operations. Furthermore, we are happy that ASFER has taken the initiative together with our partners, the European Public Health Association, EUPHA, the European Public Health Alliance, EPHA, the European Health Management Association, EMA, and EuroHealthNet and its constitutional partner with WHO Europe and the EU Commission to establish the European Agency for Public Health Education Accreditation with a global outreach. ASFER is the lead organization in advancing public health capacity in the European region. We are happy because we are leading the workforce development, which is defined in the 7 essential public health operations of European region of WHO. And what is the roadmap for 2020? The main roads is certainly recognition of the global dimension of education and training for public health in Europe and through the whole planet. And the key supporting instruments for implementation are education and training programs to be delivered in the national language and progressively in English as a key tool for global communication, international mobility organized efficiently for students and teachers in public health, innovative and affordable technologies provided for online learning and network communication, alumni contacts, especially with international students, supported and formalized for all schools and departments of public health in Europe. And public health schools must quickly adapt to changing realities, taking into account policies, needs, and limitations, and also being ready to lead in all of these areas of global health, for public health, but also to expand its role through network leadership approaches that strengthen its partners and bring mutual objectives that much closer to realization. And this is a charter which is developed by the help of all ASFER members, also members of ASFER Honors Committee, consisted of ASFER medalists and former presidents, and it is signed by Professor Helmut Brandt, just immediate past president of ASFER, Professor Julio Martin Moreno, our medalist and former president of 2000, who is still leader for our ASFER members. Then Professor Anders Forsberg, who is co-chairing our ASFER Honors Committee, Professor Julio Frank, who is also our Stamper medalist, you just had message from him, and by me. And at the end, I would really be happy to see the Europe and the world of public health, because as we heard, more and more public health is recognized as one of the solutions for the problems of the planet. Thank you very much. Yeah, thank you very much.
To finalize the session, we would like to have your very short comment on this. And perhaps, Marianne, when you read this charter, and what were your initial thoughts? What are the strengths and the weaknesses in a very short way?
I don't think I'll dwell on the weaknesses, but stay on the strengths. I think what all of us have been focusing on is the need to unite, to be able to fight for the systematic, solidaric healthcare and health systems that we all agree that we want. So this is one way of uniting and creating that strong voice that has the courage that I think that the strength of the uniting will give us to really speak out for public health. Thank you. Yes.
Thank you very much for this. Peter, any comment for us? What shall we do next?
Yeah, well, first of all, I think that there's enormous enthusiasm and commitment among young people to be trained in public health. That is a fact, and sometimes that's then later on be a bit hampered, their enthusiasm. But I think it's now time, because of the changing nature of the challenges, of the technologies, and so on, so that that we also have to take us to the next level. And I think this charter is providing a roadmap and to unite it also in a well-harmonized fashion. So thank you for doing this.
Definitely, time to revitalize even public health. Once again, well, 100 years ago, already there were many people making many contributions in public health. We have learned from them. Andreas Stamper himself was a champion. The constitution of WHO, this holistic approach of health and the definition of health, that was really inspirational. But we need to adapt to the new times. And actually, I think this needs enthusiasm. We should be absolutely optimistic. This is very much needed. And what I like, the charter is based on principles. And we need to actually develop the principles, assess the principles, and make this happen. Thank you so much.
Thank you, Rich. So the united forces of public health.
Yeah,
Vesna,
that looks very nice.
thank you very much for taking the lead in this.
Helmut, thank you very much for
and
leading this
our,
session.
and
and
our
bringing
podium,
excellent
those three eminent personalities helping to endorse the Charter. That's great. And a big thank you for you all, because we are over time. It's late at the evening, dinner is waiting in a way, but I hope you won't regret it. I think that were some insights that were worth staying. Thank you for making this happen.
So public health without frontiers.